Hey everybody, jmillen. This video is about containing your healthcare costs if you have a group plan. If this is not of interest, you can turn it off. If you're a president or owner, CEO, CFO, HR, I think this is going to be really helpful. There's a lot that people say right now with healthcare that you can't do anything to control costs. Like it's just the way it is. It's 8 to 12%. If that's you, you could probably turn this off because you're not going to open your mind at all. So all I'm asking is people like take 10% of your brain, be 90% skeptical. That's okay. Take 10% like, I'm willing to listen. I've been doing this recently. It is liberating because I'm like, hey, I got 15 minutes. Tell me what you got. Afterwards, sometimes I'm like, whoa, that is amazing. I'm so glad I was open-minded just to listen. And not a lot of listening going on right now. So I'm going to go through 4 stages of strategy you can think about over the next 3 to 5 years. A question I ask all the time is, what is your medical spend going to be 5 years from now? And I'll ask you, what is your medical spend going to be 5 years from now? My suggestion is you probably need to have a handle on that. I'm not saying it's the top of your head, but you probably have to have an analysis, a cost model, a 5-year projection, something that they do because it's going to be more for most companies. And the reason that I do this is not because I like selling insurance. I got burned myself with healthcare years ago. And then I saw employees, because I've been in the employee benefit industry in some form or fashion for almost 20 years. I saw employees getting burned. I'm like, started getting mad. I'm like, this is not right. Like we all work really hard and some of the stuff is not right. And so that's why we do it. That's why I'm doing this, to share some ideas. So my suggestion is think of the next 3 to 5 years. And again, if you're like, there's nothing you can do, or if you're fine with a 10% renewal increase every year because you guys make a lot of money, or your profit per employee is so high, it's really just pixie dust on your P&L, then don't worry about it. But for most people that I talk to in the small, mid-size area, like most of our people that companies we're talking to have between 10 and 200 employees, 250, 500 maybe, in that range, maybe up to 1,000. But not above that, right? So there's some other areas, but this is, I think, going to be helpful. The first stage that you might be in is what's called fully insured. You give the risk over to the insurance company. In exchange, you get the pleasure of getting an 8 to 12% renewal every year. You have stabilized premium. You get to pick your plan design. You get to pick your network. Like, I want a big national network. I want a little skinny network. And that's okay. For a lot of companies, that's okay. There's nothing wrong with that. That's the way the system is designed. You don't want to mess with it, and you just want to have that. And you just want to go along and understand that the challenge that we're seeing is your costs go up every year and your coverage goes down. Your costs go up, your coverage goes down. Am I not right? Deductible goes from here to here, and the cost goes up. Okay, it just got worse. And the copays go from here to here, and the cost goes up. And it's this process, or the network is this, then it becomes a regional network, and then it becomes a state network, and then it becomes a city network, and then it becomes, in some cases, just certain hospital systems. Like you only can go to these. In exchange, you get a lower rate. I'm not saying it's bad, I'm just saying that's the way it is. So fully insured is what a lot of companies, you could have 2 employees, 5 employees, you can have 300 employees and be on a fully insured plan. Not saying it's good or bad, but it's the risk you're trading off. So if you're like, hey, I'm kind of getting tired of paying more every year and making the benefits go down, you may want to consider these other strategies. The next one, self-insured. Don't freak out. I bring that up to people, and it's like funny. People are, oh, no, don't even bring that up. Looked at that 5 years ago, John. I'm like, okay, let me just tell you what's changed in the last couple of years. Remember, 3 to 5 years out. This is our strategy. This is what we need to know. Unless you don't care, we need to know these strategies are there. You may not pull the trigger today, but you may pull them later. Self-funded, self-funding, level funded. These are all kind of the same. I don't want to get too technical, but basically you take back some of the risk from the insurance carrier. In exchange, guess what? You get a little bit lower rate. There's maybe some education in there, but it's a risk shifting. Now, lots of different forms of level funded. You can have 10 employees on your medical plan and have a level funded plan, and it could be the best thing. You could, maybe we did this recently, drop the cost I don't know. I don't want to overstate. It was 12%, 15%. I don't remember. It actually made the coverage a little bit better too. So it made drop the deductible and drop the rate. So that is an option. Level funded means you're paying the same amount every month. Your employees are paying the same amount. It feels like a fully insured plan, but the mechanism is different. Don't be afraid of it. It's just the mechanism the strategy is different. Again, 3 to 5 years. Some companies I'm taking from fully insured to level funded or self-insured. Some I'm taking from level funded back to fully insured. So it's always better to go up this continuum. In this case we just worked on, it was better for them not to be self-insured. They were getting hammered with rate increases because they were overusing it. Like all the risk was showing back up on the employer, 20% plus per year increases. Like, whoa. That is the wrong strategy. We need to back it off to something else, and we became their advisor. So that's self-insured. The third one, RBP, reference-based pricing. You may have heard of brokers have heard of this term. You may not have. A lot of people are like, what is that? This has been around for a long time. In fact, your parents or you may be on a plan that's like this. What happens when the government gives health care to everyone over 65? What is that called? It's called Medicare. Medicare uses a form of this. Now, this is not Medicare. But when my dad goes to the hospital in Pennsylvania to see his specialist, that specialist is getting reimbursed the negotiated rate from the government for Medicare, whatever that procedure code is. So if it's a specialist office visit, maybe that doctor's office, according to Medicare, will get, I don't know, $105 for the visit, just for the visit. I go to that same doctor, right? And I go to my dad and I go see that same doctor with my health plan. That doctor might be getting reimbursed $300 or $400. It's just different. So our reference-based uses the same negotiating leverage of a Medicare rate, but it's not the Medicare rate. It's higher. It has to be higher because the government always gets the best deal. So you can't be the rate. But let's say it's 150% of the Medicare rate. So if a typical physician or a doctor gets reimbursed $100 for the office visit under Medicare, when I show up with an RBP plan, they're getting paid $150. And this is a fascinating strategy to be aware of because, man, can you drop cost and increase benefits? Like, wow. What's the trade-off, though? The trade-off isn't necessarily risk, although there is some risk sharing, so that there is some of that. It's education. You have to educate people because, for one thing, there are no networks. Like, what's the network? I love Anthem. I want to make sure my doctor's in the network. With these, there's no network. What do you mean? There's no what? There's a podcast below. Listen to my podcast. I'll get into a little bit. There's no network. So it's an educational offset. May not cost you risk. It may be like, well, you need someone to explain this to your employees when they enroll. You need that benefit counseling to say, this is how it works. And this is what happens in this case. And it's not perfect. And it's not for everybody. All right. Love this stuff. Can you tell? It's consortium. A consortium. I don't know if I know how to spell it, but consortium. This is another ladder. Step on that ladder. Continuum. What size company? 50 or more enrolled on medical. If you have 50 or more enrolled on your medical plan anywhere in the nation, essentially, this is an option. This is just crazy stuff. Essentially, you have this block of employees, just in your head, there's this block of employees on medical coverage from all over the country, from all industries. This is not an association plan. This is not a Christian ministry plan. This is a group health consortium that takes on new members and gets blended into the risk based on, hey, this is looking favorable, and you get accepted into the consortium. It's not, you don't just walk in and become a part of it. It's based on the risk profile. And is it good for some companies? Yes. Is it some for bad for some? Yeah. You be like, no, it's not coming in, but it's a strategy. It's a strategy that is just mind blowing. You talk about cost savings and increased benefits and talk about lasering out claims. And you talk about, you're hearing a lot of this about pharmacy costs, that pharmacy cost claims from drugs is about a third, maybe 30%, and it's growing dramatically. It's a big chunk of the cost. And so what you're seeing on medical plans is They're raising the copays up on pharmacy drugs. They're shifting drugs into higher tiers. And as you go from tier 1 to tier 2 to 3 and 4 in specialty, the amount of money that the cost sharing the employee pays starts to go up a lot. And sometimes it's not even covered. Like a tier 4 drug may have no coverage until you hit your deductible. Then you pay 20%. The problem is, and a study just came out on drugs, it's really impacting people's mortality, the ability to not die. I mean, some of these drugs are really important and people are rationing them and doing all. So it's a big problem. These plans, just as an example, can go and kind of outsource that and dramatically drop costs. Not in all situations, but in a lot, they go, whoa, you're paying all this for these drug prices. You're paying this much for insulin. Whoa, no. As part of our plan, you're going to pay this much. You still go to Walgreens and get it. So 4 different steps: fully, self, RBP, consortium. Reach out. My last suggestion is get some advice. You go to 3-4 places when you buy a new car, and yet we call people and like, no, I'm good. No. We trust our guy. I probably trust him too. But you don't know what you don't know. And just because you haven't heard of something doesn't mean it's not true. Look us up if we can help. Thanks a lot.